Welcome to the deep dive. Today, we're delving into a condition that, well, it so often perplexes both the patients experiencing its grip and, frankly, us clinicians striving to unravel its mystery: the frozen shoulder. It's a common enough presentation, isn't it? Yet it can be profoundly debilitating, really disrupting a patient's daily life. Simple actions like reaching for a cup or getting dressed can become arduous, painful challenges. We are, of course, talking about adhesive capsulitis. Now, this condition presents quite a complex puzzle. From its insidious onset, its often prolonged journey through quite distinct phases, and the nuanced approaches required for effective diagnosis and treatment. To guide us through this intricate landscape, we are incredibly fortunate to have with us today Professor Mo Imam. With his extensive experience and deep insight in orthopedic surgery, he's perfectly positioned to help us thoroughly explore this topic. Our mission today, then, is to unpack the current understanding, the clinical presentation, and the evidence-based management strategies for adhesive capsulitis. We hope to provide you, our fellow medical professionals, with valuable insights to refine your approach to this often challenging condition. So, to begin, perhaps we could just unpack this a little. What exactly are we referring to when we speak of frozen shoulder or adhesive capsulitis? I mean, these terms are often used interchangeably, aren't they? But what's the precise definition and, maybe more importantly, the core pathology underlying it?
That's absolutely the right place to start. Adhesive capsulitis is precisely defined as a chronic fibrosing condition of the shoulder. What characterizes it is an insidious and progressive, quite severe restriction of both active and passive shoulder range of motion. And crucially, this occurs without any known intrinsic disorder of the shoulder joint itself. So you can really think of it as the shoulder joint, well, almost literally freezing up.
Right.
The core pathology you see involves an initial inflammatory process within the joint capsule. This inflammation then seems to trigger what we call fibroblastic proliferation.
So the connective tissue cells multiplying.
Exactly. These fibroblasts start multiplying excessively, and this leads to a significant thickening of the joint capsule itself, the development of fibrosis, essentially scar tissue, and, quite problematically, an adherence of the capsule to itself and also to the humerus. This whole process ultimately creates a mechanical block, severely restricting the shoulder's ability to move. So understanding this adjunct inflammatory and fibrotic process helps us grasp why timing interventions carefully is so important.
That makes sense.
And while frozen shoulder is the term most people know, you'll also hear it called a stiff shoulder or contracted shoulder in clinical settings. What's often surprising, perhaps, is that it's generally considered a self-limiting condition. It tends to resolve on its own, typically within, say, 18 to 24 months.
Which sounds reassuring initially.
It does, but it's vital to acknowledge that it isn't always a straightforward resolution for everyone. Some reports indicate that a significant proportion of patients, perhaps anywhere from 20% up to 50%, can experience residual pain and limited range of motion lasting for several years beyond that typical time frame.
Years, really?
Yes, potentially. So while a natural sawing process often occurs, it can still be a very long and challenging journey for many patients.
That's certainly important to highlight that idea that not every patient simply thaws out completely, and that extended recovery can be incredibly frustrating for them. Now, moving on, who typically experiences this condition? Are there any specific demographics or predisposing factors we should be particularly aware of? Common patient profiles that might raise our index of suspicion?
Absolutely. Understanding the epidemiology gives us a much clearer picture of who's most susceptible. It affects approximately 2% to 5% of the general population.
So reasonably common in practice?
Reasonably common, yes. You'll certainly encounter it. In terms of demographics, we do see a slight predominance among women. The ratio is about 1.4 to 1 compared to men. The most common age of onset is typically between 40 and 70 years, with the mean age hovering around 55. Now, a significant point for your practice is that individuals younger than 50 seem to be at a higher risk for bilateral disease.
Affecting both shoulders.
Yes, affecting both shoulders. That can occur in up to 40%, even 50% of cases in that younger group. When it's unilateral, the non-dominant arm is, interestingly, more often affected, although why that is remains a bit of a question.
That is interesting.
Now, perhaps the most crucial risk factors are the associated comorbidities. The link with diabetes mellitus, both type 1 and type 2, is particularly strong. Very strong indeed. The prevalence of adhesive capsulitis in diabetic patients can be as high as, figures range from 10.3% up to 22.4%. That's significantly higher than in the general population.
Wow, that's a huge difference.
It is. And it's not just a statistic. For your diabetic patients, it fundamentally alters the prognosis discussion. It's also worth noting that shoulder stiffness might even be the first sign of diabetes in some patients.
Really? Presenting with a stiff shoulder first.
It can happen, which should absolutely prompt you to do a further workup for diabetes if you encounter that sort of presentation. What's also clear from the data is that outcomes for diabetic patients are generally worse, regardless of the treatment approach. They have a higher risk for bilateral disease, too. And this risk seems to increase further with older age, a longer duration of diabetes, the presence of autonomic neuropathy, and a history of myocardial infarction. It really points towards broader systemic factors being involved.
So optimizing their glycemic control becomes part of the shoulder management strategy almost.
Absolutely. It isn't just good general medical care. It's a direct intervention, potentially influencing their shoulder recovery. Beyond diabetes, thyroid disorders, both hypo and hyperthyroidism, are also significant risk factors. These are often linked to an underlying autoimmune etiology. Patients with hyperthyroidism, for instance, have about 1.22 times the risk of developing adhesive capsulitis, again, highlighting this systemic connection.
It's fascinating how interconnected it all is.
It really is. Then we have trauma and immobilization, which are also well-established triggers. This could be following something like a proximal humerus fracture or simply prolonged immobilization after other upper limb injuries or even post-surgical complications. We see it after procedures like rotator cuff repair, axillary dissection for malignancy, or even chest wall surgery.
Which really underlines the importance of early movement post-op or post-injury.
Critically important. Early, gentle mobilization is a key preventive measure here. We often say motion is lotion, and that certainly applies in trying to prevent stiffness setting in. Other associated conditions pop up too. Dupuytren's disease, for example, there's quite a striking association there, with some studies finding over 50% of adhesive capsulitis patients also having Dupuytren's. We also see links, perhaps less strongly defined but still present, with atherosclerotic disease, cervical disc disease, Parkinson's disease, and various cardiac conditions. Even cerebrovascular disease has been implicated.
It's quite a diverse list.
It is. And finally, there's growing evidence suggesting a genetic predisposition. Studies have looked at links to things like HLA-B27 positivity and specific gene polymorphisms, like for IL-6 and MMP3. This genetic component might help explain why some individuals just seem inherently more susceptible to this fibrotic process, even without an obvious external trigger.
That paints a remarkably comprehensive picture of the risk factors and those surprising systemic connections. Given all that, what's actually going on inside the shoulder? What triggers this fibrotic process at the cellular and molecular level? What are the underlying mechanisms?
Right. This is where we get into the nitty-gritty of the etiology, pathophysiology, and histopathology. It's helpful first to differentiate between two main types. We talk about primary adhesive capsulitis, which is often labeled idiopathic. This form occurs without an obvious precipitating event. It's thought to arise from some sort of intrinsic inflammatory process within the joint that then leads on to these fibrotic changes. And it's often this primary type that's associated with those systemic conditions we just discussed, like diabetes and thyroid disorders, suggesting perhaps an underlying systemic inflammatory or even autoimmune component.
Okay, so that's the out-of-the-blue type.
In essence, yes. In contrast, secondary adhesive capsulitis results from a clear external event or condition that directly impacts shoulder mobility. Common triggers here would be significant trauma leading to immobilization, perhaps postoperative complications after shoulder or even chest wall surgeries, or simply prolonged immobilization after any injury or procedure affecting the arm. Making that distinction is vital when taking the patient's history.
Understood. And the actual process within the joint.
The pathophysiology itself is, well, it's a fascinating interplay. It kicks off with an initial inflammatory response. This is what's thought to be responsible for the pain and the early limitation of motion, particularly during that initial freezing phase. Following that inflammation, the fibrotic changes really take hold. These changes seem to concentrate particularly within the rotator interval.
That specific area in the front of the shoulder?
Precisely. It's a critical triangular region of the capsule between the supraspinatus and subscapularis tendons. Within this interval, we see significant thickening of the coracohumeral ligament, the CHL, which is a key structure there, and a general contraction or shrinking of the joint capsule. Imaging studies like MRI often visualize these changes. You might see a reduced joint capsule volume, maybe some thickening of the synovial lining. At the cellular level, this fibrotic process is driven by the proliferation of fibroblasts and their transformation into myofibroblasts. These are cells that have characteristics of both fibroblasts and smooth muscle cells, meaning they can contract.
Ah, so they actively pull things tighter.
They contribute to that, yes. These cells, along with an abundant deposition of type 3 collagen, which is more like scar tissue collagen, contribute significantly to the mechanical block that restricts motion. It's generally understood that the essential lesion, the core problem area, involved the coracohumeral ligament and that rotator interval capsule. The CHL in particular becomes incredibly stiff and gets put under tension during external rotation, making it a key anatomical target for any intervention aimed at restoring movement.
So that's a real focus area.
Definitely. Furthermore, we observe an altered balance of matrix metalloproteinases, MMPs, and their inhibitors, tissue inhibitors, of metalloproteinases, NTMPs. Now, these are enzymes responsible for breaking down and remodeling the extracellular matrix, including collagen. In adhesive capsulitis, this delicate balance is disrupted. It suggests that collagen production is outstripping its degradation, leading to that excessive scar tissue formation.
An imbalance in breakdown and buildup.
Exactly. The initial inflammatory phase is supported by the finding of overexpression of various inflammatory cytokines, things like IL-1, IL-1, TNF-X, COX-1, COX-2, particularly in the bursal tissues. Mast cells, which are inflammatory cells known to regulate fibroblast activity, are often found in the affected tissues. They're thought to act as intermediaries, bridging that initial inflammatory response and the subsequent fibrotic processes.
Interesting cell type to be involved.
Yes, and delving even deeper into potential molecular links, researchers have found elevated levels of intercellular adhesion molecule 1, ICAM-1, in the capsular tissue, synovial fluid, and even the serum of patients with adhesive capsulitis. What's intriguing is that ICAM-1 levels are also elevated in diabetes mellitus. This offers a potential molecular connection, a possible reason why these two conditions are so frequently linked.
The potential biological bridge.
Possibly. We also see elevated nerve growth factors, which helps explain the often severe pain patients experience, particularly in the early stages. And critically, transforming growth factor beta, or TGF-β, seems to play a pivotal role in inducing this arthrofibrosis. Animal models have shown that overexpressing TGF-β can rapidly lead to conditions that look very much like adhesive capsulitis.
So TGF-β is a major player in the fibrosis.
It appears to be a key driver, yes, which makes it a significant focus for potential future targeted therapies. So putting it all together, on a histopathological level, what you'd see under the microscope, the affected shoulder, is characterized by synovial hyperplasia, an overgrowth of the synovial lining, angiogenesis, formation of new blood vessels, often seen in inflammation and healing, and ultimately significant joint capsule fibrosis. Clinically, this translates to a palpably thickened and contracted joint capsule. When surgeons look inside arthroscopically, they confirm these observations. They see subacromial fibrosis, proliferative synovitis, and that distinct capsular thickening. It's really quite a complex cascade, isn't it, from that initial inflammation right through to a profound fibrotic state-restricting movement.
That detailed understanding of the underlying biology really helps to demystify what's happening internally. Patients often describe a very distinct progression with this condition, almost like a story that unfolds over time. Could you walk us through the typical stages they experience? What defines each one, and what should we perhaps prepare our patients for?
Absolutely. The clinical course of adhesive capsulitis is often described in 3 distinct phases. It's vital, though, to remember that the duration and the intensity of symptoms can vary quite significantly among individuals. So these are typical guidelines rather than rigid rules, if you like.
Understood.
The first is the freezing, or painful stage. This typically lasts anywhere from, say, 6 weeks up to 9 months, though for some the gradual onset of pain might be shorter, perhaps 1 to 3 months. During this phase, patients experience that gradual onset of diffuse, disabling shoulder pain. It's often insidious appearing without a clear injury, and it characteristically worsens at night. Difficulty sleeping is a very common complaint.
Yes, the night pain seems particularly troublesome.
It really does. The pain is usually described as a dull ache, sometimes radiating into the biceps area. As this pain intensifies, arm movement becomes progressively limited. Pathologically, this corresponds to those early inflammatory changes and active synovitis we were just discussing.
Okay, so intense pain and increasing stiffness.
Exactly. Following this, we enter the frozen or stiff stage. This phase can last quite a while, from 4 to 12 months, sometimes even longer. Here, the intensity of the pain often lessens compared to the freezing stage. It might still be there, especially at end range, but stiffness and significant motion limitations become the primary concern for the patient. They experience profound capsular rigidity. This progressively restricts their range of motion across all planes, flexion, abduction, rotation, severely impacting their ability to perform activities of daily living. Things like reaching into a cupboard, getting dressed, fastening a seatbelt become incredibly challenging, sometimes impossible.
So the pain might ease slightly, but the stiffness really takes hold.
That's the hallmark of this stage. It represents the peak of those fibrotic changes and the capsular contraction. Finally, we have the thawing stage. This is the recovery phase. It typically lasts from 5 to 26 months, though again, it can sometimes be as short as 1 to 3 months for some lucky individuals. During this period, patients notice a gradual reduction in pain and a slow, gradual return of motion begins. While improvement certainly occurs, it's crucial we manage expectations here.
Because it's not always a full return.
Exactly. Complete recovery, meaning a full return to their preconditioned motion and function, is unfortunately relatively rare. Studies suggest that approximately 7% to 15% of patients may experience some permanent loss of motion, and perhaps 10% to 20% experience residual symptoms, including some stiffness and discomfort even after the condition has largely run its course.
So it really paints a picture of quite a prolonged battle for many people, from that initial painful freezing where motion is actively seized, through the rigid frozen stage, and then that slow, often frustrating thaw.
That's a very good way to put it. It's often a marathon, not a sprint.
That long tail of recovery, where a complete return to baseline isn't guaranteed for everyone, is certainly important for patient counseling. Now, thinking about the clinic, when a patient walks in and you suspect adhesive capsulitis, what are the key symptoms we should be listening for? And what's really crucial in our physical examination to confirm those suspicions and rule out other potential issues? What are the absolute must-dos during that initial assessment?
You're right. The history and the physical examination are absolutely paramount for making this diagnosis. When a patient presents, we're listening for that characteristic insidious onset of shoulder pain, often worsening at night. They'll invariably report a dull, poorly localized pain, perhaps radiating into the biceps area. They'll almost certainly describe significant difficulty with overhead movements or reaching behind their back, things that profoundly impact their daily activities. And that pain progression is a key indicator, typically very severe and sharp in the initial freezing stage, transitioning to more of a dull ache with sharp pains only at the extremes of motion during the frozen stage.
Okay, so history is key. What about the examination?
The physical examination is truly the hallmark for diagnosis here. What we're looking for is a symmetric loss of both active and passive range of motion across all planes. That means flexion, abduction, external rotation, and internal rotation.
Both active and passive. That's critical, isn't it?
Absolutely critical. This symmetric restriction, meaning the patient cannot move the arm themselves and you cannot move it for them beyond a certain point, is a key differentiating factor from many other shoulder pathologies where passive motion might be preserved even if active motion is painful or weak. It's also vital to document all the motion planes and always compare them to the unaffected contralateral side. And a really significant clinical pearl is that the external rotation deficit is often the most common and the earliest finding. If you find that external rotation is relatively preserved, your suspicion for adhesive capsulitis should probably decrease significantly.
That's a very useful tip.
As you move the arm passively, you'll typically encounter what's described as a tethered endpoint to motion. It feels like the joint is mechanically blocked, almost like hitting a taut rope, rather than the patient simply stopping you due to pain, though pain might also be present. You might also find diffuse tenderness around the joint upon palpation. On inspection, look for any muscle atrophy from disuse, or perhaps prior surgical scars if you're suspecting a secondary cause. And crucially, in true adhesive capsulitis, distal neurological function sensation and motor power in the hand and wrist should remain intact. This is a vital finding that helps us differentiate it from neurological issues like cervical radiculopathy.
Right, checking the neurology is essential.
Absolutely. Regarding provocative tests, things like impingement tests, Nearer, Hawkins, biceps tests, speed, maybe even SLAP maneuvers. These may often be positive, simply due to the altered mechanics and inflammation. However, it's important to recognize that proper rotator cuff strength testing might actually be quite limited because of the significant loss of motion. You simply can't get the arm into the required positions. What's absolutely vital, though, is to try and rule out cervical spine radiculopathy as the primary source of the pain. A negative Sperling maneuver is very helpful in that regard. Really, the combination of that characteristic history and the finding of symmetric global loss of both active and passive motion is often enough to strongly suspect adhesive capsulitis. Hashtag diagnostic precision and differential considerations.
That detailed clinical picture is immensely helpful. So with that clinical suspicion firmly established, what are our next steps in actually confirming the diagnosis and, crucially, ruling out other underlying issues? How do we best utilize things like laboratory tests and imaging in this process?
Indeed. While the diagnosis of adhesive capsulitis is primarily clinical, based on that history and examination, a thorough evaluation often involves other modalities. These help to solidify the picture, or perhaps more importantly, to rule out other conditions that could be masquerading as frozen shoulder.
Okay.
Let's first address laboratory tests. Routine lab testing is generally not indicated for directly diagnosing adhesive capsulitis itself. There's no specific blood marker for it. However, if you suspect an underlying systemic condition might be contributing, particularly diabetes or thyroid disease, then appropriate blood tests become crucial.
Like checking TSH or HbA1c.
Exactly. Checking TSH for thyroid function or HbA1c for diabetes helps identify or monitor these factors, which, as we discussed, can significantly influence the disease's progression and treatment outcomes. So it's really about looking for those associated comorbidities, not for a direct marker of the frozen shoulder itself.
Right, looking for the bigger picture. What about imaging?
Now, onto imaging. Radiographs, simple X-rays, are an essential initial step. They are primarily used to rule out other bony abnormalities, things like significant osteoarthritis, perhaps a missed posterior dislocation, or any pre-existing surgical hardware that might be causing symptoms. In very prolonged cases, you might occasionally see some disused osteopenia, a thinning of the bone. But often, the X-rays are remarkably normal.
So X-rays are mostly for ruling things out.
Primarily, yes. Magnetic resonance imaging, MRI, sometimes with arthrography where contrast is injected into the joint, is not strictly necessary for diagnosing adhesive capsulitis. The diagnosis is clinical. But MRI can be incredibly valuable.
In what way?
Well, it helps evaluate for other underlying shoulder pathologies that might mimic the symptoms, like a rotator cuff tear or labral pathology. It can also help confirm the severity of the capsular involvement in adhesive capsulitis. Typical MRI findings you might see include a loss or obliteration of the axillary recess, that little pouch at the bottom of the joint, which directly indicates capsular contracture. You might also see a thickened coracohumeral ligament, often measuring 4 millimeters or more, and a thickened rotator interval capsule, frequently 7 millimeters or more.
So quite specific signs of that thickening and shrinking.
Yes, exactly. These findings correlate with reduced joint capsule volume and can also show proliferative synovitis or even fibrosis in the subacromial space. Ultrasound can also be a useful adjunct. It's readily available and non-invasive. It might reveal thickening of the joint capsule, particularly in the rotator interval, and can sometimes demonstrate limited sliding movement of the supraspinatus tendon beneath the acromion, which aligns with that physical restriction. It's also very useful for guiding injections accurately.
That makes sense.
Lastly, a diagnostic injection test can be very informative in certain situations. This involves administering a local anesthetic, typically something like 1% lidocaine, into the subacromial space, or sometimes the glenohumeral joint itself. The key differentiating factor in true adhesive capsulitis is that the restriction of range of motion persists even after the injection has provided significant pain relief.
Ah, so the mechanical block remains even when the pain is numbed.
Precisely. This helps differentiate it from conditions like subacromial bursitis or rotator cuff tendinopathy, where the pain, and often some associated limitation in range of motion, might significantly improve once the anesthetic takes effect. That persistence of mechanical restriction despite pain relief is a strong indicator of true capsular contracture, true adhesive capsulitis.
That's a very clear diagnostic pathway. It does raise an important question, though. What other conditions might present similarly? How do we reliably distinguish them from adhesive capsulitis to ensure we get the management right and avoid those common misdiagnosis pitfalls? What should be high on our differential list?
That's an excellent and absolutely critical question because, as you say, a misdiagnosis can lead to inappropriate treatment, ineffective interventions, and ultimately prolong the patient's suffering. While adhesive capsulitis has its hallmark features, several other shoulder pathologies can certainly present with pain and restricted movement, making a careful differential diagnosis essential.
So what should we be thinking about?
Right, here's a list of conditions we must always consider. First, posterior glenohumeral dislocation. This can cause significant pain and limitation, but usually there's a clear traumatic event, and specific radiographic findings would be pretty evident on X-ray if you look carefully. Rotator cuff pathology, injury, tear, or arthropathy. Tears cause pain and weakness, especially with active motion. While they might limit active range, passive range of motion is often preserved or only minimally affected. That's a key differentiator from adhesive capsulitis, where both active and passive ROM are severely restricted globally.
That active versus passive distinction again.
Crucial. Subacromial rotator cuff impingement. This typically causes pain with overhead movements, often in a specific arc, but not usually the global restriction of motion seen in frozen shoulder. A diagnostic injection can be very helpful here, as the pain would likely improve significantly after the anesthetic. Glenohumeral arthritis. Yes, it causes stiffness and pain, but it's primarily due to joint space narrowing and osteophytes' bony spurs, which are clearly visible on x-rays. The pattern of motion loss might also differ, and the history usually involve more chronic degenerative type pain rather than that distinct freezing, frozen thawing pattern. A vascular necrosis of the shoulder. There's necrosis or death of bone tissue due to lack of blood supply. It's painful, but imaging, particularly MRI, is key for diagnosis. Neuropathic Charcot joint. This is a severe progressive joint destruction resulting from nerve damage. It's rare in the shoulder but causes marked instability and destruction, very different from the stiffness of adhesive capsulitis and obvious on imaging. Cervical disc disease or radiculopathy. Nerve compression in the neck can absolutely refer pain to the shoulder and arm and cause weakness. However, the passive range of motion of the shoulder joint itself often remains relatively preserved. Testing neck movements and performing tests like the Sperling maneuver are vital here.
Checking the neck is always important with shoulder pain.
Always. Biceps issues like subluxation or tendonitis. These cause pain along the biceps tendon, often worsened by specific movements, but don't typically lead to that global symmetric loss of passive and active motion. SLAP lesions, tears, and labrum often cause pain with overhead activities, maybe some clicking or popping, but again, not the profound global stiffness. And finally, multidirectional shoulder instability, MDI. This involves excessive laxity in multiple directions, leading to a feeling of instability or the shoulder slipping, rather than the profound stiffness characteristic of adhesive capsulitis. But to reiterate, the absolute hallmark feature that helps differentiate adhesive capsulitis from many, if not all, of these other shoulder pathologies is that marked reduction in both active and passive range of motion in multiple planes, especially external rotation. If a patient presents with significant shoulder pain and they can't lift their arm actively, but you can passively move it through a near normal range, even if it's painful for them, then it's highly unlikely to be adhesive capsulitis.
That global symmetric restriction of both active and passive motion is the diagnostic cornerstone we rely on. You really can't overstate its importance. Never forget that difference.
That's incredibly helpful for navigating the diagnostic maze. Right then, let's turn our attention to treatment. Once we've confidently diagnosed adhesive capsulitis, what's the initial approach? What does the current understanding suggest for non-surgical options? I understand these are often the mainstay, aren't they?
Indeed they are. Non-surgical treatments are generally the first line of defense, and actually they're often remarkably effective. The primary focus here is really twofold: controlling the pain effectively and diligently working to restore motion and eventually strength. And it's also critical, as we touched on earlier, to optimize any underlying health conditions that might be contributing, especially in diabetic patients. Ensuring their glucose control is as good as it can significantly aid the shoulder's recovery. That's a point we really can't overstate.
A holistic view from the start.
Absolutely. Now, physical therapy, or physiotherapy, is undeniably the cornerstone of treatment. It's all about gentle, pain-free, progressive stretching. Often incorporating moist heat beforehand can help prepare the tissues. This could be supervised therapy, perhaps initially, or a well-structured home exercise program that the patient follows diligently. While supervised sessions are often recommended for, say, 3 to 6 months, there's actually some ongoing debate about the optimal intensity.
Oh, more isn't always better.
Not necessarily. Some evidence suggests that a gentle thawing approach, or even what's sometimes termed supervised neglect, with very gentle exercises like pendulum swings, can be equally effective or perhaps even superior to more intensive, painful physical therapy, particularly in the early stages. High rates of satisfactory outcomes have been shown with quite simple stretching programs.
That's interesting. So pushing through intense pain might be counterproductive?
It certainly might be, especially in that early inflammatory freezing stage. The focus should be on gentle, persistent stretching within tolerable limits. Specific exercises like the external rotation passive stretch using a doorway, forward flexion done lying supine, and the crossover arm stretch are common examples. These exercises can sometimes be combined with other modalities provided by the therapist, things like ultrasound, electrical stimulation, manual therapy techniques, shortwave diathermy, low-level laser therapy, even hydrotherapy, primarily to help enhance pain relief and facilitate movement. For instance, posterior glide mobilization techniques are often used and considered effective for improving external rotation.
Okay, so physiotherapy is key. What about medications?
For pharmacological therapy, the goal is primarily symptomatic management, really supporting those physical therapy efforts by making the exercises more tolerable. Non-steroidal anti-inflammatory drugs, NSAIDs, are commonly recommended for short-term pain relief. They're particularly useful in the early, more inflammatory stages as they target the underlying synovitis. However, while they help with pain, studies haven't consistently shown significant objective improvements in shoulder mobility with NSAIDs alone.
So they help manage symptoms but don't fix the stiffness itself.
Broadly speaking, yes. Systemic oral corticosteroids, like a short course of prednisone or prednisolone, can lead to a faster improvement in pain and disability in the short term. However, this benefit may not be sustained beyond, say, 6 weeks, and there's always a potential for rebound symptoms once the medication is stopped. Plus, the systemic side effects need consideration. So it's often seen as a short-term bridge, not a long-term solution. Intra-articular corticosteroid injections directly into the glenohumeral joint often offer faster and potentially superior improvement in symptoms compared to oral steroids. They work, we think, by decreasing the fibromatosis and the presence of those myofibroblasts within the shoulder capsule.
Targeting the inflammation and fibrosis locally.
Exactly. While they can provide rapid pain relief and improve range of motion, the long-term difference compared to physiotherapy alone might not be sustained, perhaps at 6 months or a year. Some studies show that while injections might improve self-assessed disability at 6 weeks, physiotherapy might specifically improve passive external rotation more effectively. Interestingly, combining both doesn't always seem to lead to significantly better long-term benefits than either modality alone in some studies.
So injection gives quick relief, but long-term gains might come more from the physio.
That's a reasonable summary of some of the evidence, yes. Though injections can certainly facilitate participation in physio. Sodium hyaluronate intra-articular injection is another option. This is sometimes called viscosupplementation. It's considered chondroprotective, helping protect cartilage. Studies have shown it can provide outcomes equivalent to corticosteroid injections in terms of range of motion, pain, and functional scores in the short term. It also appears quite safe. There's some evidence suggesting that a combined injection of sodium hyaluronate with a steroid alongside physiotherapy might yield better overall improvements in both pain and joint motion compared to just steroid and physiotherapy alone. That combination approach is interesting.
Multiple agents working together, potentially.
Potentially, yes. Then we have nerve blocks, specifically the suprascapular nerve block, SSNB. This is a really valuable tool in my view. The suprascapular nerve supplies sensation to about 70% of the glenohumeral joint, so blocking it provides significant, albeit temporary, pain relief.
Allowing a window for movement.
Precisely. This can be critical in facilitating mobilization and enabling more effective physical therapy. It allows patients to push through stiffness that intense pain would otherwise completely prevent. Studies show improved short-term pain, and some evidence suggests better pain control and range of motion even at 3 months compared to intra-articular steroids alone. Using ultrasound or EMG guidance for the block seems to be more effective than landmark-based approaches. And finally, there's hydrodilation, also known as distension arthrography or brisement. This involves injecting a large volume of sterile fluid, typically saline, often mixed with a corticosteroid and local anesthetic into the joint under imaging guidance, like fluoroscopy or ultrasound.
Physically stretching the capsule from the inside.
That's the idea. It aims to mechanically stretch the contracted capsule, potentially disrupting some adhesions and increasing the intracapsular volume. The cortisone provides an anti-inflammatory effect too. It can certainly improve pain and disability, especially in the short to medium term, say 3 to 12 weeks, though again some longer-term studies suggest it may show no significant difference compared to a standard steroid injection alone. There are also a few other non-operative therapies being explored, things like whole-body cryotherapy, WBC, using extreme cold for anti-inflammatory and analgesic effects, potentially improving pain, ROM, and function. And even botulinum toxin type A, BONT/A injections, are being looked at as an alternative to steroids, showing maybe similar short-term effects, but at a considerably higher cost, so its role is still really being defined.
That's a really comprehensive array of non-operative options. But inevitably, sometimes these measures just aren't enough. If conservative management isn't yielding the desired results after a decent trial, when do we start considering surgical intervention? And what are the primary techniques involved? This must feel like quite a significant step for patients.
It is a significant step, and rightly so. Surgical interventions are generally reserved for patients with persistent disabling symptoms that have proven refractory unresponsive to a prolonged course of non-operative modalities. Typically, we're looking at a period of, say, 3 to 6 months of dedicated conservative management, perhaps slightly shorter, maybe 6 to 12 weeks if symptoms are severe and continue unabated despite a rigorous non-operative regimen. Surgery is most often considered and offered during that frozen or stage 2 phase of the condition where stiffness is the predominant issue and the acute intense pain has usually subsided somewhat.
Okay, so timing matters. What are the options?
The first surgical option often discussed is manipulation under anesthesia, MUA. The procedure itself involves, quite literally, manipulating the shoulder joint aggressively while the patient is fully anesthetized and their muscles are completely relaxed. The goal is to forcibly tear the adhesions and stretch that contracted capsule beyond the normal pain thresholds, something impossible to achieve while the patient is awake.
Sounds quite forceful.
It is. And while often regarded as relatively safe when done carefully, it carries notable risks. These include potential complications like humeral fractures, glenohumeral joint dislocation, tearing the rotator cuff tendons or the labrum, and even brachial plexus nerve palsies, stretch injuries to the nerves. These are more likely if the manipulation is perhaps overzealous or if the patient has underlying osteoporotic bone which is more fragile. Bleeding into the joint, hematorosis, can also occur. These are not insignificant risks and need careful discussion.
Absolutely. And how effective is it?
Well, its effectiveness is actually somewhat controversial. It's generally not recommended during the very early inflammatory freezing phase, as you might just stir things up and make the inflammation worse. Furthermore, MUA has been shown to be significantly less effective in diabetic patients, with some studies reporting failure rates as high as 50%. There are even studies suggesting that MUA combined with home exercises provides pretty comparable outcomes to just home exercises alone, or that pharmacotherapy and physiotherapy might yield better subjective results than MUA in some patient groups. So it's certainly not a guaranteed fix, and its role is perhaps diminishing slightly compared to other techniques.
Okay, so MUA has its place, but also limitations and risks. What's the alternative?
The second and increasingly preferred surgical option is arthroscopic capsular release. This is generally considered a highly effective and safe method for treating resistant adhesive capsulitis. Its key advantages are quite significant. Firstly, it allows the surgeon to look directly inside the joint with a camera arthroscopy. This confirms the diagnosis visually and, importantly, allows us to rule out any other potential pathologies that might have been missed with non-invasive imaging. Secondly, and critically, it allows the surgeon to directly see and precisely release the tightened structures, specifically the coracohumeral ligament, the thickened rotator interval, and the contracted capsule itself. This ensures an adequate release under direct vision, which is a major advantage over a blind manipulation.
More targeted and controlled.
Exactly. The technique typically involves using specialized instruments through small keyhole incisions to release those tight intra-articular structures. The focus is often on releasing the rotator interval from the front of the biceps tendon down to the top edge of the subscapularis tendon, and specifically releasing that thickened coracohumeral ligament. Sometimes a posterior capsular release is also performed to help improve internal rotation and crossbody adduction. A subacromial prosectomy, removing inflamed bursa tissue and releasing any adhesions there, might be done as needed, though an acromioplasty, shaving bone, is generally not indicated just for adhesive capsulitis. In many cases, a surgeon might combine the arthroscopic release with a gentle MUA at the end to ensure maximum range of motion is achieved, but this is done very judiciously after the capsule has been released.
And recovery after this procedure.
Recovery from arthroscopic capsular release absolutely necessitates immediate, early, and quite aggressive postoperative physical therapy. This is crucial to maintain the motion that was achieved during the surgery. Without it, the scar tissue can reform, and the gains can quickly be lost. Recovery times typically range from about 6 weeks to 3 months for significant functional improvement.
So the physiotherapy post-op is non-negotiable.
Absolutely non-negotiable. In terms of outcomes, most patients have good results with reduced pain and significantly improved range of motion. Long-term outcomes are generally positive. However, some degree of stiffness can persist, even after a successful release. And again, diabetic patients, frustratingly, often continue to experience some degree of stiffness even after surgical intervention, reinforcing that systemic influence. Recurrence of stiffness is possible, perhaps up to around 11% at 1 year in some series. Factors like being female, over 50, and having type 2 diabetes tend to correlate with less favorable outcomes post-surgery. which highlights the need for careful preoperative counseling about realistic expectations.
Important factors to consider. What about complications?
Complications are generally less common than with MUA alone. The primary specific concern with arthroscopic release is potential injury to the axillary nerve. This nerve runs quite close to the inferior aspect of the capsule. Therefore, performing the inferior release carefully, often staying close to the glenoid rim, the socket, is essential to mitigate this risk. Surgical site infection is a very rare but possible general surgical complication. Other risks like fracture or brachial plexopathy are much more associated with the MUA component if that's performed concurrently and perhaps too forcefully. Lastly, just to mention open capsulotomy. This involves a larger incision to release the capsule. It's rarely performed nowadays because the arthroscopic techniques offer smaller wounds, generally shorter recovery times, and comparable effectiveness. However, it remains an option, perhaps if arthroscopic release fails to achieve the desired outcome for some reason.
Okay. And you mentioned physiotherapy being key. Post-op pain management must be vital too.
Absolutely vital. Postoperative pain management is crucial for success. Adequate pain control perhaps achieved using methods like an intra-articular pain catheter delivering local anesthetic, sometimes a cervical epidural infusion, or more commonly an interscale nerve block placed preoperatively is absolutely essential. This isn't just about patient comfort, although that's important. Effective pain relief directly enables patients to comfortably engage in that immediate, essential postoperative physical therapy. Without good pain control, they simply won't be able to tolerate the exercises needed to maintain the surgically achieved motion and prevent recurrence of the arthrofibrosis. It's an absolutely key piece of the postoperative puzzle. Tag prognosis, complications, and the broader picture of care.
It's certainly clear that the treatment pathway, especially when involves surgery, requires really meticulous planning and execution, including that post-op phase. Now, looking at the long game, what can patients generally expect in terms of their recovery journey? What factors might influence the ultimate outcome? What's the overall prognosis for adhesive capsulitis, and how should we be counseling our patients about this?
The prognosis for adhesive capsulitis is, generally speaking, pretty good, particularly if it's diagnosed reasonably early and managed appropriately. It is, as we've established, fundamentally a self-limited disease. It tends to resolve on its own over time. But, and this is a big but for the patient, this recovery typically occurs over a lengthy span, usually 1 to 3 years. That's a long time for someone to be in pain or significantly limited functionally.
3 years is a huge chunk of life.
It really is. And while approximately 80% of patients do regain near normal or normal shoulder function with proper treatment, it's really important to manage expectations. Complete recovery, meaning a full, unrestricted return to their preconditioned motion and function, is actually infrequent. Around 10% to 20% of patients may still experience some residual symptoms, including a degree of stiffness and perhaps some discomfort, even after the acute phases have passed. This means they might not fully regain the range of motion they had before it started, and that's something we must communicate clearly and realistically to them.
So tempering expectations is key.
Absolutely. And crucially, individuals with those comorbid conditions we discussed, particularly diabetes, mellitus, or thyroid dysfunction, commonly have a longer and often more severe course of adhesive capsulitis. This inevitably leads to a less favorable prognosis overall. We consistently see that diabetic patients, even after surgical intervention, often have continued shoulder stiffness, highlighting the profound systemic influence of these underlying diseases on their recovery potential. Their journey is also more arduous and the endpoint less complete.
That's a sobering reality for those patients.
It is. And beyond the purely physical aspects, we absolutely must consider the psychological factors. These play a significant and often underestimated role in the patient's experience and outcome. Things like pain-related fear, anxiety, and depression can profoundly influence patient-reported outcomes, their perceived shoulder function, their level of disability, and their overall pain experience. Patients frequently report feelings of intense frustration, a significant loss of independence due to the limitations imposed by the condition. They can feel quite isolated.
It affects their whole life, not just their shoulder.
Precisely. These emotional and psychological burdens can exacerbate their distress and negatively impact their willingness and ability to engage fully with therapy, thereby influencing their ultimate physical prognosis. It's a condition that truly impacts much more than just the joint itself.
That's such a powerful reminder of the holistic nature of patient care. And of course, no medical condition or intervention is entirely without its complexities or potential downsides. What are the potential complications we need to be aware of, both from the condition itself and from the various treatments we've discussed? What should we be explicitly discussing with patients as part of the informed consent process?
That's a vital consideration for ensuring truly shared decision-making with our patients. First, let's look at potential complications arising from the condition itself. The most common issues are simply the persistence of residual shoulder pain and stiffness. As we just discussed, this can last long after the primary phases are expected to have resolved, becoming a source of ongoing frustration and limitation. Also, prolonged immobility due to the condition can lead to significant deconditioning of the shoulder girdle muscles. This can make the shoulder more vulnerable to additional injuries down the line. We sometimes see secondary issues like labral tears or even rotator cuff tears developing, possibly due to excessive stress on the capsule and adjacent structures as patients try to compensate or force movement through the stiff joint.
Okay, so the condition itself has long-term implications. What about the treatments?
Now, regarding complications arising from treatments, with manipulation under anesthesia, MUA, the risks are perhaps more acute and potentially more severe due to the forceful nature of the procedure. These include serious concerns such as humeral fractures, breaking the arm bone, biceps or subscapularis tendon ruptures, glenohumeral joint dislocation, the shoulder popping out, and rotator cuff tears. There's also that risk of brachial plexus palsies nerve injuries, particularly following overzealous manipulation or in patients with fragile osteoporotic bone. These are significant potential complications that demand a very frank discussion beforehand. For arthroscopic capsular release, while generally considered safer due to the controlled nature of the release, the primary specific concern is axillary nerve injury. As mentioned, this nerve runs close to the inferior capsule. Careful surgical technique, especially during the inferior release near the glenoid rim, is essential to minimize this risk. Surgical site infection is a very rare but possible general surgical complication with any arthroscopic procedure. And overall, patients, especially those with diabetes, may still experience residual stiffness even after a technically successful surgery, as we noted when discussing prognosis. The key is to be aware of these risks, discuss them openly with patients, tailor the treatment approach appropriately, and set realistic expectations from the outset.
That brings us really nicely to how we as healthcare professionals can best support our patients through what is clearly a challenging condition, going beyond just the clinical procedures. How does the interprofessional healthcare team ideally come together to optimize outcomes? It seems absolutely clear that this isn't a condition for isolated practitioners, that team approach feels critical here.
You've hit on an absolutely crucial point. This really gets to the heart of delivering effective, patient-centered care for a condition like adhesive capsulitis. It's definitely not just about the specific medical or surgical interventions. It's about supporting the whole person through their journey.
So what does that look like in practice?
Well, first and foremost, patient education is absolutely vital. Providing patients with clear, concise explanations of adhesive capsulitis, what it is, its characteristic pain and stiffness, and importantly, its natural progression through those freezing, frozen, and thawing phases is fundamental. This foundational understanding helps manage their expectations, which is huge. It reduces the often significant anxiety they experience. What's wrong with me? Will it ever get better? And profoundly improves their compliance with treatment protocols, particularly the often lengthy physiotherapy. Patients often feel disempowered or deeply frustrated if they don't understand why they're experiencing what they are or how long it might realistically last. An empathetic explanation of the long and variable course of the disease really empowers them.
Setting the stage for the journey ahead.
Exactly. We also need to stress preventive measures where possible. This includes ensuring prompt recovery of shoulder mobility after any injury or surgery, actively preventing the prolonged immobilization that can trigger this condition in susceptible individuals. Effective management of underlying systemic diseases, particularly diabetes through optimizing HbA1c levels, is also a key preventive or management strategy. Encouraging regular participation in customized exercise programs to maintain general shoulder mobility and strength is crucial for everyone, but especially those at higher risk. An early intervention should be initiated whenever prolonged immobility is anticipated, for example, after a fracture requiring immobilization.
Proactive steps where possible.
Precisely. Now, achieving truly enhanced healthcare team outcomes absolutely demands a collaborative interprofessional approach. No single clinician can effectively manage this condition in isolation. It really takes a village. Primary care clinicians are often the first point of contact, They're responsible for that initial evaluation, making crucial initial management decisions, and knowing when to make a timely referral to specialists like orthopedic surgeons or pain management teams. Physical therapists play such a critical, hands-on role. They guide patients through the specific exercises for pain reduction and mobility improvement, developing individualized rehabilitation protocols. They are often the daily guides for the patient on their recovery journey.
They're really central, aren't they?
Hugely central. Occupational therapists are also essential, particularly when function is severely limited. They provide practical strategies to help patients improve their performance of daily activities affected by the shoulder dysfunction. Things like dressing, personal care, cooking, helping them adapt and maintain as much independence as possible. Nurses, especially practice nurses or specialist nurses, are crucial for providing ongoing patient information, support, monitoring progress, and often being that consistent point of contact for patient queries and concerns. Orthopedic specialists step in primarily for diagnostic clarification in complex cases and for surgical intervention when conservative measures are no longer sufficient, offering their specific expertise in those procedures. And pain management teams can be essential, particularly in severe or refractory cases. As we've discussed, effective pain control is what allows patients to actively participate in their physical therapy, which is absolutely non-negotiable for recovery. Without adequate pain control, therapy can become impossible or ineffective.
It's a real multidisciplinary effort.
It has to be. And underpinning all of this is effective communication and collaboration among these professionals. This means utilizing shared electronic health records effectively, maintaining open lines of communication, picking up the phone, and ideally having mechanisms for regular team updates or meetings to ensure everyone is aligned on the patient's progress, their response to treatment, and the overall management plan. This coordinated care ensures consistency and adherence to current clinical guidelines. And finally, we must always underscore the profound psychological impact and the importance of support networks and true patient-centered care. We need to actively acknowledge and validate the patient's experience, address their often unspoken feelings of frustration, sometimes even shame about their limitations, and that significant loss of independence they often report. Prioritizing effective pain management isn't just about physical comfort. It significantly improves psychological well-being. When pain is better controlled, patients feel more empowered, less anxious, and more able to engage fully and effectively in their physical therapies, which ultimately leads to better overall outcomes. It really is about treating the person, not just the shoulder joint, and recognizing the very real burden this condition places on their entire life.
That's such a powerful call for integrated, empathetic care, really acknowledging the full scope of the patient's experience. It's so important. As we start to wrap up our deep dive into adhesive capsulitis, perhaps looking to the future, what's on the horizon, both for understanding its pathophysiology even better and perhaps for developing even more effective treatments. Where is the research heading?
Yes, the future of adhesive capsulitis management is certainly an active area of research, which is encouraging. There's a definite push towards developing novel, non-operative therapeutic interventions that specifically target the underlying inflammatory or fibrotic processes, moving beyond just symptomatic relief toward actually modifying the disease process itself.
Targeting the root cause more directly.
That's the goal. One particularly interesting area is enzymatic capsulotomy, using enzymes like collagenase. Collagenase is an enzyme derived from a bacterium Clostridium histolyticum that specifically breaks down the peptide bonds in collagen. It's already FDA approved and used clinically for other fibrotic disorders like Dupuytren's disease in the hand and Peyronie's disease, both of which share some histological and molecular similarities with phytorhosis seen in adhesive capsulitis.
So using an enzyme to dissolve the scar tissue.
That's the principle, yes. Early studies are now investigating the off-label use of collagenase injections directly into the shoulder joint for adhesive capsulitis. Initial results seem promising, showing potential improvements in functional scores, shoulder motion, and pain. Now, these are still in the relatively early phases of research, needing larger trials to confirm safety and efficacy. But the concept of directly breaking down that excessive fibrotic tissue rather than just mechanically stretching it or suppressing inflammation is certainly compelling. It represents a potential paradigm shift in treatment if proven successful.
That sounds very promising indeed. Anything else on the horizon?
Another area that has been considered is the exploration of anti-TNF agents. These are drugs that target tumor necrosis factor alpha, a key inflammatory cytokine. While these agents are well established and effective in treating other inflammatory conditions like rheumatoid arthritis, their application specifically in adhesive capsulitis hasn't been well studied to date. Some initial pilot studies have actually shown limited or no efficacy currently. This might suggest that the inflammatory pathways driving adhesive capsulitis are perhaps more complex or involve different primary mediators than those effectively targeted by the current anti-TNF drugs. So that particular avenue requires more nuanced investigation to see if there's a role, perhaps for different anti-cytokine therapies.
So maybe not TNF, but other inflammatory targets?
Potentially. And beyond specific pharmacological agents, there's a significant ongoing focus on developing and utilizing better, more validated animal models of adhesive capsulitis. Historically, research progress has been hampered somewhat by the lack of good animal models that accurately replicate the human condition. However, newer models, for instance involving specific types of shoulder immobilization in rats or rabbits, are now showing more promise in replicating the key features we see in humans: the progressive loss of range of motion, the capsular adhesions, the specific collagen accumulation patterns. These improved models, which allow for more detailed molecular studies and long-term functional measurements, are crucial. They pave the way for more rigorous preclinical testing of new pharmacological therapies, and will undoubtedly provide deeper insights into the complex disease mechanisms. Hopefully, this will lead to more targeted and effective treatments emerging in the coming years.
That's certainly encouraging to hear about the ongoing research and the potential for new therapeutic avenues. As we conclude our discussion today, what would you say are the absolute key clinical pearls you'd like our listeners, our colleagues who are mid-senior medical professionals, to really take away and remember about managing this challenging condition in their day-to-day practice? What are the non-negotiables from this deep dive?
Certainly. If I were to distill our conversation down into the most important clinical insights for the practicing professional managing adhesive capsulitis, I'd highlight these points. First, the hallmark trait. Remember, the significant loss of both passive and active range of motion, particularly external rotation, is key. If passive motion is largely preserved, think very carefully it's probably not adhesive capsulitis. Second, pathophysiology. Keep in mind it's that complex interplay of initial inflammation leading to progressive fibrosis within the joint capsule and synovium. Understanding this helps inform treatment timing and rationale why aggressive stretching might hurt early on, and why future therapies might target fibrosis directly. Third, diagnosis. It remains primarily a clinical diagnosis based on history and examination. Imaging, like X-ray and sometimes MRI, is crucial mainly to rule out other underlying pathologies, not necessarily to definitively diagnose adhesive capsulitis itself. Likewise, laboratory testing is for investigating associated systemic diseases like diabetes or thyroid issues, not for a direct marker of the shoulder condition. Fourth, prognosis. Counsel patients that while it's generally self-limiting, the course is often prolonged months to years. Manage their expectations accordingly. Be especially mindful that patients with diabetes commonly experience worse outcomes and more persistent stiffness, even after surgery, making their management particularly challenging and requiring specific counseling. Fifth, the treatment cornerstone. Physiotherapy remains the primary treatment modality, focused on gentle, progressive stretching, often in conjunction with effective pain management strategies. Conservative management should always be the first line, with surgery reserved for refractory cases considered at the appropriate stage, usually stage 2. Fifth, the treatment cornerstone. And finally, always embrace a holistic approach. Recognize the critical role of interprofessional collaboration, working closely with physios, OTs, pain teams, and combine this with comprehensive patient education and robust psychological support. This integrated approach is paramount to achieving optimal outcomes and effectively managing patient expectations throughout their often frustrating journey. Remember to treat the patient, not just the shoulder.
Professor Imam, thank you so much for guiding us through the complexities of adhesive capsulitis today with such remarkable clarity and invaluable insight. Your expertise has truly illuminated this challenging condition for us, and I'm sure for everyone listening. To our listeners, we really hope this deep dive has provided you with a clearer, perhaps more nuanced understanding of adhesive capsulitis. We hope it's equipped you with practical insights to better support your patients and navigate this often difficult condition more effectively in your practice. If you found this discussion valuable, please do take just a moment to rate and share the deep dive. Your feedback and sharing truly helps us reach more curious minds like yours in the medical community, allowing us to continue providing these in-depth explorations. Thank you so much for joining us, and we look forward to our next deep dive.